Hi everyone, I'm Dawn Cramer, and I am going to be summarizing an article. And the article I decided to discuss is Dr. Drake's major or minor neurocognitive disorder due to traumatic brain injury. He uses the DSM-5, it's the 294.11, and as you can see in parentheses, the letter F 02.8. There are many cognitive disorders, such as dementia, delirium, and amnesia, which have undergone considerable changes to their classifications. The cognitive disorders are now grouped together in a different category. The differences are based on the cause acquired and the category of mild or severe. The reason for these changes were because clinicians were challenging the diagnostic term, which was literally defined as loss of mind. And the clinicians did not like this term at all. And so that is why they decided to change it. Several terms that were not accurate are now replaced under the new classification. Some examples are MCI, which stands for mild cognitive impairment with and without amnesia, or cognitive impairment, not dementia, and minor neurocognitive disorder. Today, there are many people with MCI that are not diagnosed with mental illness, but in the past almost always were diagnosed with a mental illness. The DSM criteria for diagnosing dementia has changed to include judgment impairment, social cognition, an ability as to be able to recognize or reproduce a design, areas of language, learning and memory, executive ability, and complex attention. Symptoms of major or minor neurocognitive disorder due to traumatic brain injury is my next section I'll be talking about. During the Greek and Roman times, traumatic brain injury, also known as TBI, in most circumstances was deadly. However, during those times, electrical currents from eels and fish were used to help with recovery. The article didn't really discuss if these treatments worked. The study of TBI was first partly researched by looking at gunshot wounds of the head during the Civil War era by surgeon Chris Holm. Chris Holm outlined the first steps towards helping to take care of those with a head trauma. There were many people with traumatic brain injury that died from septic complications because of their wounds becoming infected. The German armies were the first to realize that there was a need for neurological and psychiatric care for those who endured wounds. The Allied armies realized this as well and agree with the German armies. Aphasia is the loss of ability to speak or understand due to brain damage. The Gestalt therapy was established from the study of aphasia, which aided to Goldstein's work in the brain and mind formation. The United States participated in studying finding ways to help with traumatic brain injury. The United States had 3 correct-to-speech teachers available at Cape May, New Jersey's Hospital for Head Injury. The hospital was also the very first place to begin speech and language rehabilitation for aphasia. Next part I'm going to talk about is the impact. In the past, traumatic brain injury was mainly concerned a medical problem among the military. However, today it is a major civilian problem, more so because of motor vehicle accidents, concussions, and sports-related injuries. Roughly 1.7 million traumatic brain injuries occur every year, and 1.4 million people go to the emergency room department, which leads to 275,000 hospitalizations and, sadly, 52,000 deaths. The people most likely to have traumatic brain injury are children under the age of 4, 15 to 19-year-olds, and adults over the age of 65. However, the people over 75 between the years 2002 and 2006 accounted for most hospitalizations and deaths relating to traumatic brain injury, and males prevail over females within all age groups. Cognition assessments are based on mental state exams, neuropsychological tests, and applying cognitive skills to everyday life, which could help us to answer what type or kind of motivation a person has or possibly does not have. Traumatic brain injury can often cause a lack of motivation, and in extreme cases, a kinetic mutism. A kinetic mutism is when the person is awake and visually aware but cannot make any other responses. Some manifestations of a lesser head trauma include impairment with speech and behavior, declining emotional responses, and psychomotor abnormalities. The ability to plan action and react is intact, but reduced efforts take place in the most common forms of traumatic brain injury. The extent to which there is a post-traumatic cognitive impairment depends upon how severe the focal brain injuries are and the amount of axonal injury that occurred. Axonal injury is when the brain quickly shifts inside the skull as injury occurs. Manifestations of general cognitive include interferences that affect the ability to maintain thoughts and conversations, impairments on being able to hold attention on more than one thought, which affects multitasking skills, and problems with being declarative, and to a smaller degree affecting a person's long-term memory. A person's working memory can be hindered by frontal lobe lesions. An example of a person's working memory would be the ability to remember to pay a bill. Executive functions of the brain, such as goal setting, making plans, being able to put events in the correct sequencing order, and to hold back on inappropriate behaviors can be affected by traumatic brain injury. Some more common neurovegetative symptoms are depression, anxiety, being tired, being irritable, decreased sex drive, having a harder time concentrating and paying attention, decline of memory. Minor head injuries may cause headaches, repeated dizziness, blurred vision, loss of hearing, ringing in the ears, nausea, vomiting, and a decline in taste and smell. The next section I am going to be talking about is the diagnostic criteria. Major neurocognitive disorder is an extensive, diminishing form from levels of past conducts in one or more cognitive areas, which include attention, memory, language, and perceptual motor skills. The deficits need to be observable, tested, or not a result of delirium, and not better explained under a different medical disorder. Minor neurocognitive disorder should not hinder a person's everyday independence. However, evidence of diminished abilities from former levels of abilities with one or more declines in the cognitive domains should be stated by friends, family, or a clinician. They may have concerns since this can be used as evidence. As with a major neurocognitive disorder, minor neurocognitive disorder issues should not be from delirium or fall under a better fit for a mental disorder. Treatment is the next section I'm going to be talking about, and the main choice of treatment is a multifaceted inpatient rehabilitation from those who suffer severe traumatic brain injury. The next step is an outpatient setting with a speech and language therapist. It is also important to have support groups set in place to help the person with their recovery. Prescribed medication is still debatable, and further studies need to be conducted. Sometimes the medication helps people with traumatic brain injury, but in other cases there is no help for the medication. I have listed 5 national resources which you can take a look at and read through, and thank you for watching the presentation.